Hello, I'm Dr. Lalit Chimpi. I'm a consultant gastroenterologist, hepatologist, and interventional endoscopist at Pune, practicing at Jahangir Hospital and the Nanak Mangeshkar Hospital for the last 15 years. So, coming to how you manage AKT-induced hepatotoxicity, I think the first thing that, as far as AKT-induced hepatotoxicity is concerned, is the pre-treatment evaluation. So, always before starting any patients on AKT, I think it's very important that you should screen for pre-existing chronic liver diseases which may be undiagnosed. You should ask a history about alcohol consumption, and if there is significant alcohol consumption, you need to ask the patient to stop alcohol. History of IV drug abuse. You also need to assess them and their nutrition in detail. The baseline investigation should always include other hepatotropic viruses, for example, hepatitis B, hepatitis C. One should always also do an HIV test in these patients, because it has been seen in some studies that AKT-induced hepatitis can occur more commonly or may become more severe, especially in immunosuppressed individuals. So this risk of AKT-induced hepatitis is definitely there in these patients with pre-existing liver disease, and one might need to monitor more carefully, as well as change the treatment protocols in case chronic liver disease is suspected to be there in significant amounts, or if patient has cirrhosis, decompensation, that one needs when needs to think about a risk benefit ratio when one is starting AKT. What about choice of drugs and regimens for AKT? So there is no evidence to suggest that various regimens, for example, thrice a week regimen, is associated with lower risk of hepatotoxicity than daily regimens. The guidelines provide advice on the choice of drugs, combination, and duration of therapy, and which are generally suitable to different clinical scenarios. But one should always consider the cost issues, affordability, access, as well as efficacy, and the associated adverse events to or adverse effects of many of these drugs. Considering that combination therapy increases the risk of daily, monotherapy with either INH or rifampicinin may be preferable as treatment when you are suspecting latent tuberculosis in individuals, particularly if they are higher risk of hepatotoxicity. So I think it's important to monitor treatment and monitor liver enzymes in a lot of these patients, especially early in the disease when they may become symptomatic. So if patients come back to you saying that they have new onset symptoms after starting AKT, especially like nausea or anorexia, it should kind of click that one needs to be more vigilant in monitoring and do their liver function test to see whether they are developing AKT-induced hepatitis. Therapeutic drug monitoring has shown to improve clinical response, but its use in predicting hepatotoxicity is not really been demonstrated. And uh, so, therapeutic drug monitoring practically a lot of times is not possible in our scenario. Those without any obvious risk factors, but with some liver biochemistry based monitoring, can be considered in asymptomatic. But as a practice, I generally don't monitor a liver function test of all patients who are started on AKT, but I do tell them that in case they develop symptoms, they should report immediately, because AKT-induced hepatitis is not very uncommon in our practice. As far as intervention and treatment is concerned, I think prompt withdrawal of the offending medication is the most critical and most important intervention that you need to do in all of these patients. And considering that there are no specific markers to distinguish patients who will resolve on their own or patients who will go on to develop more potentially serious DILI and ALF or acute liver failure, I think the thresholds for stopping AKT should be remain pragmatic rather than evidence based. In generally, whenever there is an elevation of ALT which rises to more than 3 times the upper limit normal, where this is obviously AKT-induced hepatitis, then one needs to stop all the antitubercular medications, and then you need to put them on the ones which are safer as far as liver is concerned. So you can continue on ethambutol, you can add streptomycin, and you can add quinolones, to the therapeutic regimen, because the tuberculosis itself needs to be continued to be treated while you are managing the liver part of it. Most of the times, people who have AKT-induced hepatitis will have a mild disease, especially if picked up early and the medications are stopped. Management of, to summarize, AKT-induced hepatitis, the first thing obviously is to stop the implicated agents. And that itself is the major treatment, because that itself takes care of uh, the treatment, and the transaminases will come back to normal in a few days in most people. For those who have more severe or moderate disease, I think supportive treatment is important. Those who develop acute liver failure or go to a stage where transplantation may be required, I think they should be counseled early, and early liver transplant may save these patients from severe acute liver injury because of these drugs. Thank you.